Good morning to you all once again. Those who have just joined, you are most welcome. It is 10 minutes past the hour. We are going to start as we continue to mobilize more health workers to join the webinar. I'll be guiding you through the process, assisted by Sister Evelyn. Sister Evelyn, are you in?
Yes,
Checking.
Commissioner, I am in.
Great. So Biko moderating the session, and if you can put the slide in slideshow mode, and we uh, put the slide in slideshow mode. Yes. So this is how we will handle the webinar. This is the outline. And without much ado, I want to request Catherine, are you in to lead us in an opening prayer? If you're in, if you're not, any other volunteer?
Let us pray. We love you, O Lord, for this morning, for this gift of life. We have never taken it for granted, but because of your mercy, love, you have made it for us to see the next day. And we put all this day into your hands for what is going to come, for what we are going to receive. We thank you in advance. You are God, God of all seasons, God who is going to see us through even this pandemic of Ebola and more infections. We thank you that we are able to have something that we can do to prevent, to treat, and to bring life back, and also to elevate life and pain. We thank you and glorify your name, and we put this meeting and whatever is going to be said in this meeting into your hands for your glory. In the mighty name of Jesus Christ our Lord, I pray. Amen.
Amen. And we are going to have this as one of the series of webinars that are continuing to continue to empower ourselves with the knowledge. Knowledge is power, to be able to defend and protect our lives as we serve, but also to save the customers that who are our clients and the population as they use the services that we offer. So you're most welcome. And I will now hand it over to the Director General Health Services to give us a word to open this webinar. Over to you, Director General.
Okay, thank you, Dr. Stavia. Good morning, wherever you are, and welcome to today's webinar. And would really want to speak to you on the ongoing outbreak. And there are a few areas which I want to highlight. As of today, we have so far 19 confirmed cases, and we've definitely had 2 fatalities. And we have 5 health workers, and we have 14 cases which are imported, which are definitely Congolese, and we have 5 local cases. But what I want to emphasize definitely is the issues of the 5 cases which are involving the health workers. But also I want to give a warning that when we talk of 14 imported cases, it does not, I don't want it to say that no people to start saying this is a Congolese infection, this is non-Uganda, because if we lose guard, then we have a very high risk of this outbreak spreading. And so this webinar is purposely really want to targeting health workers, because you are the front line, and you definitely, because of the nature of your work, you run a risk of getting exposure. So we want how we should be able to increase vigilance, how you should be able to be friendly, and if there's any season in your practice where IPC should be one of your, it's not an option, it's a must have and a must do. So we need to be able to look at that. But also we note definitely the majority of these patients so far have kind of tried to gravitate more to the private health facilities. But I am also very cognizant that if now they have realized that there's a very close follow-up in the private facilities, they are soon going to the public facilities. We are doing active search. We are trying to do active search across both public and private facilities. I want also to reassure our colleagues in the private sector that, first of all, we've been working together, because I have heard others say either we're trying to victimize the private facilities. Why is there no case in the public facilities? I don't think it's so. These are people who are endowed, they have money. If they're able to charter a plane, most cases, their first area of priority would need that they go to to a private facility. So we need just to understand that, and we need to be able to follow that. So you need to get yourself not, because the first thing is, how do you, also what we note, because as probably they will share with you, that most of the names which we have here are real, these people have decided to change themselves to Ugandan names. So you will find names like Mugisha, you'll find probably different names, which are Ugandan names, and actually you can be hoodwinked that these are Ugandans, and then you do on. What we also have noted that if you get in a patient who is arriving at hospital, an emergency arriving at hospital at 1 a.m., 2 p.m., 3 p.m., 3 a.m. at night, and they know very well that they come at a time when the issues of triage are very low, you should be very suspicious, because we are also noting that most of them are presenting to the hospitals at a very late hours of the what, and sometimes definitely they get booked into a private facilities. So we read that you take guard of this. The other aspect also which you should be able to look at, apart from the travel history and probably if there's NAP link, is issue that they present just like any malaria. There will be a fever, headache, abdominal pain, GIT symptoms, diarrhea, probably vomiting, extreme body pain, really severe body pain, because there's, depending on the viremia. So you need to be able to look at that. So bleeding, so far the persons whom we have had, bleeding appears when they are dying. Actually, it comes at the end part of it. Or if you happen to do a blood, if you see a thrombocytopenia of unexplained, you need to be very suspicious of what? Suspicious of some of these what? Cases. Now, in aspect of surveillance, I also want to bring this very clear warning that if you take a sample, first sample, and then you send to the lab, and it's run and they tell you negative, take it with a pinch of salt, because we have noted that a majority of them, initially, some of them test negative, but if the symptoms persist, when you repeat it in after 72 hours, the results becomes positive. So I would not want that when you do a first test, then you say, we have ruled Ebola, or you have ruled an hemorrhagic fever. So these are some of the key things which I want that you take note and be able to do it and be able to take that. We've so far seen patients who have moved from one facility to another, actually putting the health workers at a risk, one facility after the others. So Kampala remains the high risk so far because most of these cases have been picked from Kampala. Arua or West Nile remains as an entry point, and that's why we would want that want to engage with the transporters because the last seven cases which we picked, which are all related, and they divided themselves and came in different groups. They came from West Nile. I don't want to say from Arua, but we do not know where they entered from. They were dropped. We picked our alerts. We picked them early. So we need to be able to, as sales workers, practice IPC and make it that you should be able to have it at most times. If you get exposure, I have mentioned this again. If you have exposure and you have manifestation of, it's prudent that you come early so that we start the supportive treatment early, because as I did mention that what normally causes us to lose this patient is because they get kidney injury and then the rest of the other organ failure comes in. So we really would want to support with early rehydration and management of these patients. So I want to thank again the organizers for scheduling this meeting, and they will speak. We are working with the government of Congo. We think that we should be able to set up some treatment facilities across the Ugandan border, because even if whatever we do, these people will continue to come. So we're thinking of setting a treatment facility in Aru, another treatment facility in Kasenyi. I think our teams are doing simulation today to see so that before they leave, they should be able to do one. But I am sure there are cases which will still continue to do one, to come to Uganda, because the information given across that we have a medicine which treats Ebola and we're refusing to share it. So they will continue to do one. So let's do what within our means. Let's avoid exposing ourselves, exposing our families, and exposing other patients. So I would really want to end there, and once again thank Stavia. Yeah.
Okay, thank you so much, EG, for those remarks full of wisdom and also passion to the healthcare workforce in our country, to make sure that they take guard, to make sure that they don't lower their guard as far as IPC is concerned. Don't touch patients with your bare hands at the bare minimum. If you can always have gloves on, regardless of whether you are in the high burden districts or not, and use them appropriately, because also there is misuse of gloves even when you use them, so that we protect ourselves. Disinfect as appropriately, wash their hands as frequently as you can, and do the active search. That is what is going to save us all. We make sure that we identify people who are approaching us for services and have them further interrogated in case we find they meet the criteria for suspected cases, for better management without exposing everybody in the facility. But also accidentally exposed, take care to do the necessary measures to ensure that in case you get symptoms, you are in safe hands, but also you protect others without further exposing them by seeking care in non-gazetted places. With that, we now go into the details. You'll keep the questions coming through the chat, and there are people on the chat, colleagues from the Ministry of Health, from the regional EOCs, who will be giving us responses through the chat as well. So we have our speakers, they're already with us. We start with the first speaker, who is going to give us more details about Ebola and how we can participate in the response, what we can do, how we can quickly detect suspected cases wherever we are. Let me invite Dr. Sande, who is our first speaker. Dr. Sande, I hope you're on the call. Yes, he started sharing his screen. Take us through the first session of the day. Over to you, Dr. Sande.
Thank you, Chair, for organizing this, and thank you, DG, for the opening remarks. Allow me to take you through the Ebola readiness in practice, since most of our colleagues here are health workers, to see what we need to do. So as a way of opening, this Ebola is caused by infection with a virus within the genus of Ebola virus. We have 6 species of this Ebola. We have the Zaire, Bundibujo, Reston, Sudan virus, Thai forest virus, and Bomabali virus. But for today, we shall focus ourselves on the Bundibujo virus. As of 15th May 2026, Uganda declared an outbreak following a confirmation of a case in Kampala City. And this outbreak was linked to the active outbreak in DRC that I had stated earlier. And also, this is our second of such a kind. The first was in Bundibujo, 2007, where even most of our health workers succumbed to this virus, including the Dr. Kule, the principal nursing officer there, and the rest of the colleagues that were in the Bundibujo hospital that succumbed to this death. This also had previous outbreaks, like the one of Province Hotel in 2012. Since then, we have no approved vaccine, no therapeutic agents against this virus of Ebola. So the treatment as of now is just to optimize supportive care, as DG has explained, that we manage the symptoms as they come by until the person improves throughout. The natural reservoir is a fruit bat of the family Pteropodia, which are thought to be the hosts of the Ebola virus. They are found in the flavivirus triangle, of which Uganda is part of this triangle. These bats are infected, but for them, they do not get sick or show any signs of illness once they are affected. So they will remain flying as well. They will remain moving around. So really, you may not find them that a number of them has fallen on the ground to show that there's an infection among those bats. They can excrete the virus in their blood, saliva, in their urine, and even in their feces. So the virus is maintained in the fruit bat population. The infected bats spread the virus as they travel by. They come to the mangoes, they come to the trees. And in these places here also, you find that the primates, like the chimpanzees, the monkeys, they become infected when they become direct contact with the other animals, which cause a large epidemic in animals such as these gorillas and other mammals. From there, you find that the monkeys, the gorillas, the bats, they interact with human beings, and the initial transmission begins from there to the human being, from the animal side to the human beings. whereby the human beings are handling infected animals or by contact with items contaminated with infected animals, or knowingly or unknowingly, because I've seen apparently that most of the people, they go to even to wind to interact with some of these gorillas. Then once the initial human being is infected, they come and interact with the fellow human beings. This leads to subsequent transmission from person to person, which occur through direct contact with the body fluids, body secretions, and organs of the infected individuals. The important risk of transmission during the care of patients are during the care of the deceased, during the funeral, where everyone come and do the last office, wants to see the last person, wants to confirm. In our tradition here in Africa, where people want first touch whether the person has died. And we're told that the dead body is the most infectious in all this cycle. So where is the Ebola virus found in an infected person? It's found in all body fluids of someone who is sick or has died of Ebola. The virus can remain in the privileged sites of the human, like in the testes, in the breasts, or in the anterior chamber of the eye. Even when this person has recovered, this virus can remain there. It can be excreted in this breast milk, even in the semen. I'm told that in Congo, 7 of these outbreaks have been caused by such kind of interaction where body fluids like semen are passed on to the opposite person, and then leads to an outbreak like that. So we have to avoid the sweat, the blood fluids, the diarrhea, the vomitus, the sperms, the amniotic fluids, the breast milk, and all that. As you know that in our case, in one of our cases, like the driver handled the vomitus of one of the patients. So we know that that one clearly can spread the disease. Clinical presentation of Ebola virus disease. We have to know that the infection occurs after exposure of a person who is sick or has died of Ebola. Allow me to put a pointer here so that you can be able to follow up closely. So this point here, you see this person is sick, and it starts with the person being in contact with the sick person. This person also goes into an incubation period, which lasts from 2 to 21 days. Usually by the 14th day, this person will have started feeling unwell. So without these symptoms, the person cannot pass on the virus at that time. So this phase is a non-contagious phase. So from the phase of incubation, someone goes into the dry phase and presents with signs of fatigue, fever, headache, joint pain, muscle pain, back pain, sore throat. And this is really similar to what we have in individual virus. The individual you find in the previous outbreak, the publication shows that someone would present with fever, fatigue, and headache only. And these people would be positive for individual virus. Then from this phase, they transition to the wet phase, with the common signs and symptoms being diarrhea, nausea and vomiting. Bleeding occurs in some cases they don't bleed, hiccups, they can have red eye. This is here, at this stage here, people become more contagious. Then the person becomes more contagious as they progress. Sometimes they die. Once they have died, at this stage here, this is the most highly contagious of all the phases. So we need to be very cognizant of the incubation period, the dry phase, and the wet phase of this illness. The symptoms are vague and resemble those of other common diseases that we know, such as malaria, typhoid, septicemia, acute kidney injury, brucellosis. Even co-infection is possible with other conditions. Signs and symptoms of EVD can vary from person to person. So depending on someone's immunity, if you are diabetic, if you're hypertensive, if you're on chemotherapy, for sure your immunity is a little bit low and your presentation may be vague than any other person. So bleeding is not always present, so don't wait for bleeding in most of the cases. Chances of survival increases if treatment is administered early in the disease course. That's why we're having good outcomes of treatment here in Uganda, because we identify early and we initiate treatment early, so the immunity of that individual is able to carry him through the recovery process of the body. Here, looking at the case definition, I know you may be having an access to this chart already, but allow me to say that the case definition is a standard set of clinical and exposure criteria used to decide whether the person is suspected, probable, or confirmed Ebola case. Applied at every screening point to guide who is referred for isolation, sampling, or testing. And also keep a copy of this national EVD case definition at each screening station as shown. So it has about 4 components. It has the community case definition. This is for the VHTs, where the illness with onset of fever or no response to treatment, or at least one of the following signs, such as bleeding from the nose or other body parts, blood diarrhea, blood urine, or any sudden death within the community. Of course, our community people are able to tell that someone has been sick for some time, or whether 2 days, or more than 3 days, or 4 days. They can tell you that that colleague of ours has been sick. Then you can go to the suspected case definition here. This is divided into 2, based on whether you have a laboratory in your area or you have no laboratory. So if you have a laboratory, we say illness with onset of fever or a negative laboratory diagnosis for usual causes of fever. At least most of us know the usual causes, as we said earlier on, the malaria, septicemia, and all that. And at least 3 of the following signs, such as headache, vomiting, diarrhea, anorexia, loss of appetite, lethargy, stomach pain, aching muscles or joints, difficulty swallowing, breathing difficulties, or hiccups, or even convulsions in some cases, or illness with onset of fever and no response to treatment for usual causes of fever, and at least one of the following signs, such as blood diarrhea, as already set up there. This works if you have a laboratory capacity. But if you have no laboratory capacity, for example, the screening points at the border points, you find that they will rely on the thermometer guns. So we say any person with a history of fever greater than 38 degrees, and at least one of the following: history of contact with the suspect, probable or confirmed Ebola case, or history of travel to an area with a confirmed outbreak of Ebola. In our case here, we have Congo, which is in our neighborhood, or sudden or unexplained death, or unexplained bleeding. So this suspect too will apply. Then we have a probable case. This is a person who died from suspected EVD and has an epidemiological linkage to a confirmed case, but was not tested and not have laboratory confirmation of this disease. So, but we know that actually this person touched or was close to a person who has been under treatment, or whom we know that died of the Ebola disease. We can really classify also these probables in terms of closeness to this person, whether they stay in the same house, whether in the same workplace, or they work in the same institution, or they travel together in the same vehicle. So that person will say really had an epidemiological linkage. The confirmed case here really a suspected case with a positive laboratory results for either virus antigen or to a viral RNA detection by PCR or IgM antibodies against Ebola. So all these cases, they are well captured in our case definition for Ebola, and they are available for use and even on the social media. So looking at the risk categorization, I know most of you are very conversant with this map. We know that the northern Uganda, starting from Lamu, coming to West Nile, coming to Western Uganda, and coming to Southwestern Uganda, these places are very high risk. Then looking at also their trade routes, from West Nile, from Western Uganda, from Southwestern Uganda, these are highways, so they have been put under the category of high risk. And the rest of the country is at moderate risk. Actually, on the last desk, we realized that even we're getting so many alerts regarding Ebola from even as far as Kabong, Moroto, Nakapripidi. So the whole country is at a moderate, the rest of the country. So detection of Ebola case at the facility. So this is looking at the facility-based surveillance, and I want to thank DG for approving the event-based surveillance guidelines. We shall be circulating them soon. But looking at the event-based surveillance, the facility-based surveillance, we start with the issue of screening at the facility. What is screening? This is the process of evaluating individuals for the presence of symptoms, exposure, or risk factors related to a particular infectious disease. Why do we screen? For early detection of cases to minimize contact with others. We have seen that once one person is infected, almost the whole country may be infected because of the closeness of these people. That's why I want to have the close look at these people and to screen them. Why should it be done? Why should it be done at every entrance gate into a health facility? At all departments, inpatient or outpatient? If not possible for all, close some entrances. If you have about 3 gates, but you have capacity for only 1 gate, please close the other gates so that you're able to screen at the entrance. But if you have capacity to have all gates functional, you can open them, but you screen. Who should be screened? Everyone. Even health workers should be screened. Patients should be screened. Visitors, caretakers. We have such a scenario in Chivuli, what happened when the caretakers became sick. So, and have a tendency of not screening our fellow health workers. They just come with familiarity and they just enter the health facility and exit at will. So, Chair, I think also we have to have the health workers screened as they enter in the morning and also screened as they go back home so that we're able to detect at what time the health workers are having signs and symptoms as early as possible before interacting with the rest of the colleagues. So how primary screening? All facilities should set up a screening station at all entrances. Primary screening should be conducted by trained personnel. Those that have signs and symptoms related to Ebola should be recorded in a signal log and sent to the secondary screening station. Clients that do not have these signs and symptoms, these signs should be channeled to the regular care pathway. Screeners should maintain a minimum PPE when screening. Here we mean that someone should not put on like someone who's going to the moon, but just minimum PPE to avoid infecting themselves. So screening equipment are supplies for people entering the facility. A hand hygiene station should be set up there. A chair, if needed, placed at a 90-degree angle for the screeners. A mask for the patients with respiratory symptoms, because we said also the mucus. The nasal mucus also can be infected. For screeners or healthcare workers, a copy of the Ebola case definition should be close by. Hand hygiene supplies, a physical barrier like even a desk should be in between or a plexiglass. Infrared thermometer and spare battery should be there. Ebola screening algorithms, I will not show it to you as we move down. A register or a signal list or a signal log should be also placed where you're able to note some of these people. Minimal PPE, if a distance of at least 1 meter cannot be maintained, and a full PPE as needed for emergency and spills. This is recommended for high-risk PPE kit available if it's nearby for those people to be used. For cleaning and waste management, cleaning materials and PPE for cleaning to use if needed. Waste bins as needed should be labeled accordingly. I think nowadays they've reduced them from 4 to 3, so they should be placed accordingly and used accordingly. So you can see how we're doing the screening. Someone is entering, you have to maintain that distance. And if need be, you have to put if you can't maintain that, you have to put a barrier so that you don't come closer to the person who is being screened. A gun thermometer, but also sanitizer should be closer by. And also you should have areas where you can note someone when he's sick. Then you should have 2 pathways, one for those who are suspected to be sick, and also a regular pathway for those who are not sick. From there, you go to secondary screening. Because if you have identified from the primary screen that someone is sick, it takes a different path. There, they will find someone who is more qualified or more senior This should be conducted by a clinician in a designated secondary screening area. The screening should be guided by a standard case definition. Clients that do not meet the case definition should be channeled to the regular care pathway. Clients that meet the case definition should be channeled to the facility isolation unit or to a designated holding area as they wait for evacuation. For now, we have an evacuation protocol, so you don't just call for a border or call for a taxi to come and evacuate someone. Call for an ambulance to come and evacuate this. There we shall be knowing that we have not infected any other person. So this is the screening algorithm. This is the algorithm. Ask everyone at each point of entry, have you experienced any two of the following recently, or either signs and symptoms or exposure categories in this case. For signs and symptoms, fever greater than 38 or higher, unexplained bleeding, extreme tiredness or weakness, headache, anorexia or loss of appetite, shortness of breath, hiccup, abdominal pain, diarrhea, vomiting or nausea, muscle or joint pain, fits or convulsions, someone is not alert or confused, or someone has presented with the red eyes. Go ahead and find out about the exposure. Any history of travel to EVD-affected region, or sudden unexplained death in the community that this person has interacted with or has participated in a burying, contact with a suspect or a probable or confirmed case. So you have to get also the exposure history. Then there, you come and look at the actions for suspected EVD. Here we say maintain patient in isolation area while waiting for the clinician to come and verify this. The trained clinician should maintain a safe distance. If not possible, don't approach PPEs for suspected EVD using the body system. Do not do it alone. Don't be an expert on donning. Call another colleague to come and support you, to put on and also to don and doff. Capture the demographic information for this person, like the name or the nickname that they used. Remember in 2022, in Jinja, we almost failed to get the suspect because he was using a nickname from the ghetto. And for us, they are giving us the real name. So if you know the nickname, also put it there. The date of birth, the sex, the phone number of this person, the head of the household where the person comes from, the district, the name of the patient, the parent, the name of the parent or the guardian, the age, the possibility of pregnancy if someone is a woman, the ordinary residence, the village or neighborhood, and also the occupation. This information helps up with if the person, for example, was negative initially, and maybe the health workers have left him to go, but later on, you may think that probably this person may have progressed and follow up. So you're able to have the contacts with you and follow up with that person. So this is the integrated alert reporting and information sharing. Looking at the health facility, you have a reporter, maybe a health worker. This person here reports the facility event-based surveillance focal person, who in turn verifies this information and then sends it to the district surveillance focal person in the DHO's office. This information can be routed to the regional referral at the regional emergency operations center or straight to the Ministry of Health through the National Emergency Operations Center. There also you can have feedback by the technical officers at every level, and they can give you guidance. So you don't have to be in this alone. You can get support at all levels, either from the district or from the region or from the ministry. Steps in event-based surveillance: once you have such a person whom you have detected, whether in the community or in the facility, or you have seen this in the media within your area, triage, assess for relevance at the alert desk, and also do a verification. This can be by phone call to call other people to find out whether it is truly happening or it's just something like a rumor. So, or you can go to the field and do field verification and confirm that what they're talking about is true. Number 4, do the risk assessment, find out who is at risk. Are they children? Is it a school? Is it a market? Is it the health workers? Or is it the institution where this person is working? Then there you can suggest appropriate measure or public health intervention that you need to provide. Alert all appropriate authorities, notify them. This should be done within 24 hours so that they intervene as soon as possible. Then also there we can respond. We can coordinate public health actions that are required, either tell those people to remain in that place until appropriate measures have been suggested, like probably taking them to isolation, or isolate whoever has signs and symptoms at that moment is part of the response, or treat what can be treated. How to report? You can report through our toll-free 0800 1066, or you can send an alert SMS to 6767, or you can scan the QR code, which brings you to alert.health.go.ug. So either you can scan the QR code, or you can place in the alert.health.go.ug. All of this will bring you to if you scan this, it will bring you to this page here. You can see that we have if you go to your computer, you can put in alert.health.go.ug. It will bring to this page where there's Uganda Health Alert System. Here there's an area for where you can see the case definition. And also, if you have access, you can log in to see what has been captured from various districts, how they are reporting. So you can enter into the date, the time, and the status of Chair, if you can allow me, probably I can show this. I'll show this physically so that everyone can be able to follow up, so that I can finish this presentation, but I upload my screen so that I can take in everyone for like maybe 2 minutes extra to see how it's done in real time. Otherwise, after logging, after logging in that, then you can report. So in a way to come to the conclusion of this presentation, we say frequent hand washing and use of sanitizer is very, very important. Avoid direct contact with affected people and body fluids. Use personal protective equipments. Safe body practices should be in place. Early isolation and treatment of affected individuals. Community awareness and vaccination where available. Enhance IPC, activate surveillance and risk communication. Please, there should be continuity of essential healthcare services at all levels. Even this includes public healthcare nursing, where our nurses have to go back to the community and continue the vaccination activities in their unit posts that they have established. And also conduct the readiness assessment in the districts at the point of entry, even the health facility. In the readiness assessment, see what you have before you have the suspects. Look at the PPEs that you have, look at the disinfectants, look at the medicines, the fluids, the antibiotics. It's part of readiness. Also, you train your health workers. I remember when the COVID-19 came, most of us were heading health facility, we didn't know what to do, even what to train to your health workers because there was no information. But for now, there's enough information about Ebola, so we know what to speak. So it's better that we should not assume that health workers know everything. We have to go back and retrain them on important aspects. Ebola is a dangerous but preventable disease. Early detection and a proper infection control saves lives. Community operation is essential in outbreak response. So where the community is able to report, really it eases your time in terms of detection. Thank you, Chair, for listening. Allow me for the 2 minutes I requested for, so that I'm able to share my screen. Share, this is the Uganda Health Alert System. Once you go to Uganda Health Alert System here, it brings you this area here. You don't need a password to enter it. It's an open access for reporting. But also, if you're not sure, you can come to this area where there is EVD definition here. You find the case definition, you find the community case definition, suspected case definition, all that available for you to consider if you're not sure of the case definition with the patient you're having. So from there, you can report your alert. You note the day, you can pick it like 6th today. You can come the time, it will just pick that time automatically. The status, if this person is alive or dead or is unknown, If it's alive, you can say it's alive. The call taker, maybe it's Dr. Sandy. Has this been reported before? I can say no. The person, your name, I can put my name as a reporter and telephone contact. Source of this alert, where is it coming from? Are you in the community? Are you a community member? Are you a VHT? Are you in the health facility? Are you a health worker? In the school? Are you in a math gathering? At the point of entry, or you have seen this on social media, you can report that, you can tell us that, probably straight in the social media. What are we responding to? You know, our integrated disease surveillance has a list of priority diseases for Uganda, and they have been put here, including Ebola. Ebola virus. This Ebola virus has been specified, has been brought out clearly because of the ongoing disease, but they can be under the viral hemorrhagic fevers. In that case here, you can pick it. You pick the location where you're reporting from. The districts have been provided for, maybe Arua City. If you know the sub-county, you can tell us the sub-county. You can tell us the village and the parish. However, if you don't know them, we have not made them mandatory, but we have made the district mandatory for the sake that because for them they're always known. You can tell us about the case of this information, the patient name, the age. You can just pick it, maybe 20. Well, if he's a male, the next of kin, and the telephone contact, and also probably you can have a small description, maybe found dead, maybe found unconscious. From there, you can continue and give us additional notes of this patient. Then you can come and pick what you think. If you have a gun thermometer, you can pick what's appropriate that you're seeing from this person here. There, with that ease, you can submit that alert. So once you submit it, someone like me who has the logins, I can just come to the logins. I put in the password, we got a health alert system, and sign in. This is real time, so I'm able to see what you have placed into the system. I can know how many from the dashboard, how many have been verified, but I can come here to the call log here. I can see the alerts which have come through. Like today, we have so far had one alert coming from Kampala. We shall follow it up and spending verification. Then that helps us to know that really someone has reported, and then it's from a community. And the team in the surveillance is able to follow up with that community member and find out. For those people who use 6767, if I go there, probably also you can come here if you have enough time. You can look at the details of this call and do the verification, either desk verification. If you're not convinced, you can go ahead and do the share. So you can see that that this case here of Kampala here, I can come here and do the verification. I can verify this alert. So the colleague who's going to verify will come to verify the alert or make a phone call there. If he's not convinced with the information given, he can go and do the field verification. So looking at what the person who has reported has submitted, he's telling us that the reporter is Yosia Walama, has given us his contact, and he's from Makindye, Salama village. He's reported that above name at 4 a.m. experienced signs and symptoms of diarrhea, body weakness, night sweats. He took ORS and some Metro. He's a businessman working in town, but now he's feeling fine, advised to stay indoors. So for us, this is what this person has given us. Our person will call that person to get more information about that case, and then they follow up. So that's how this is some of the ways we get these alerts. Or if you have sent to 6767, we're able to also receive that unstructured information. For today, people are just verifying most of the information. So also we can receive that, but also I can come here and look at the details and review the details of this. This one said a suspected 7-month male baby with fever, diarrhea, pneumonia that started on 27th, resident of Rubaga division. So if this person since 27 has been sick, it means we need to follow up why it's long and why this person reporting now. So it is something that worth following up. The same samples have been collected. They're suspecting hemorrhagic fever. So anyway, this has already been verified. The results came out to be negative. So this was on 3rd. So you can see, but also this person became a suspect because had taken long without responding to medications. So, Chair, thank you so much. This is what I wanted to share with you from the surveillance aspects and the readiness at during the surveillance.
Thank you so much, Dr. Sande. I imagine the people who have listened to your talk since you started have acquired knowledge to participate in the response to make sure that there's adequate preparedness at where they are, including their safety. Colleagues will be having some questions in the chat room. As we go along, you'll find time to go through some of the questions and we see how we are doing. But also inform us of what else you'd want to know as we plan for the next webinars and where you do practice in different facilities. So we have had the 4 stages once you get exposed, from infection to a period of intubation, the dry phase to the wet phase. If you become unfortunate and the patient dies, the dead person is the most infectious person we have. So wherever we are every day, in some facilities we lose some patients. Let's take care. If we have not ascertained their cause of death and so on, let's be careful how we handle the dead. And that includes the people who are not able to attend this webinar, our cleaners and the people of the mortuary who work in our different facilities. Let's empower them and be sure that everyone is protected. When you protect your neighbor, you also are protected. If you get the knowledge and don't pass it on to the other people you work with, all of you are not protected. Because if I get exposed, my exposure may reach you in one way or the other. I will now invite Sister Evelyn. I have seen all your questions. You want the slides? Our IT team will make sure all of you have attended, received the slides. If it is possible, we shall also deposit them on the chat if they have been shared with the admin team. Invite Evelyn to take us through the next presentation, which will focus in detail on what to do to protect ourselves. What are the basic minimum in terms of IPC? Over to you, Evelyn. Hello, Evelyn. Okay, if Evelyn cannot hear me, let's go to the next presenter. Colleagues, we are still continuing with the session. We haven't yet finished. Our next speaker is an expert in infection prevention and control. And this is Dr. Katwesi J. Elizabeth, who is leading our IPC at the Ministry of Health. IPC is not for only when we are dealing with outbreaks. IPC is part of business as we offer services. We need to have that change of mentality in IPC practicing, and we make sure it is part and parcel of how we do business. Over to you, Dr. Katwesi. Katwesi. We shall have the question and answer session after this presentation. Matthias, is it okay? If you are speaking, Elizabeth, you are muted. I'm not hearing you. Elizabeth, is it my
Thank
side,
you.
colleagues?
Yeah, thank you
Oh,
very much,
go
Chair.
ahead.
Sorry, our host had not allowed us to unmute, but now I guess I can be. Thank you very much, Commissioner. Thank you very much, colleagues, and the previous speaker. I will try to emphasize aspects that have come out through the previous webinars, but in case we need any additional information, this can always be shared through or talked about the subsequent webinars. In particular, we'll be looking at some of the IPC precautions, just to highlight that the IPC precautions require knowledge, which we are giving here. They require us, the healthcare workers, to practice the precautions that we've learned, but also require our leaders to provide the things that we are utilizing for the precautions. The
Elizabeth?
Chair, can you still hear me? Sorry, I dropped off briefly, internet glitch.
You are on now. We've been waiting.
Isaac, you can hear me?
Yes, we can hear you. Are you able to hear us?
All right, thank you very much. So because the virus is, please. So I was mentioning that because the virus has a lipid envelope, anything that destroys this envelope can render the virus inactive. This includes soap, chlorine, alcohol-based hand rub, and even the open environment like exposing to the sun, which is the basis for the precautions that we are talking about for IPC. The transmission Sunday has labored to explain a lot. I will not go back to this, but my emphasis from the IPC perspective is that over and above the direct contact with patients, we should also take caution for exposure to contaminated surfaces. So the reusable medical devices, the patient care equipment, including the beds and the environment within which we operate, should be well decontaminated because the virus can also be on these organisms. And also, most of the healthcare worker infections usually occur when a healthcare worker measures to prevent themselves from acquiring the infection. Hence, high index of suspicion is very key. Dr. Sunday has highlighted the signs and symptoms. The emphasis from the IPC perspective is that because the patients are presenting with these non-specific symptoms, screening and having a high index of suspicion is very key, because by the time they get the advanced stage symptoms like bleeding, they've already been through an infectious phase for some time. Hence, every patient you're coming into contact with, you need to adhere to the standard precautions. Regarding the incubation period, I saw some questions still coming through the chat. This was highlighted about 2 to 21 days. This is very key, especially for us that are admitting patients, because a patient can come in with another indication for admission, road traffic accident, any other acute requirement to come to the hospital while they're in the infectious period. So while they're in the incubation period, and while they're on the ward, during the incubation period, they develop symptoms. So screening is not only for the patients at the entrance, but also patients that are admitted in all their wards for any other reason. This should be done ongoing every day so that we're able to detect the first onset of symptoms, put the isolation precautions and notification precautions in place. The infectious prevention is, but the key for us is to ensure that we identify, isolate, and rapidly notify these suspected cases of Ebola early so that we minimize contamination of very many places in the healthcare facility, but exposure to very many healthcare workers along the chains of care. The standard precautions include hand hygiene, wearing personal protective equipment, management of sharps, safe waste management, management of the linens, environmental cleaning, and patient care equipment, and risk assessment, which we shall talk about in detail in these slides that are coming through. The standard precautions are precautions that should be used by patients for all patients at all times, irrespective of risk. And these include an array of precautions that are actually part and parcel of our routine operations with or without Ebola. And once we suspect an Ebola case, then there are added precautions come into place, which we shall be seeing as we go into the next presentation. Very key is screening. Everyone keeps talking about screening. This should be done at the first point of contact with the healthcare system, which is at the entrance, meaning we need to have one entrance or designated entrances whereby screening can be set up 24 hours throughout, and observing at a distance, non-contact temperature taking, and asking questions according to the case definition, and does not require close contact or physical contact. And then this does not remove the need to triage the patients, which is assessing for severity so that you can prioritize who needs care first. In the context of an Ebola outbreak, we need to be able to screen the patients before we triage them, because at triage, we are in close contact with the patients. We are required to do some key tests. You want to do blood sugar, you want to position the patient, which means that you should have had a quick screen to eliminate the suspects, because the PPE you are going to use will be determined by if you think the patient meets case definition or not, rather than just rushing in and then later you discover that it could be a suspect when you've already exposed yourself. And then isolation really is separating the patient from others to minimize the spread. This is a layout of how to set up your screening station. In principle, to have an area where healthcare workers are screening at a distance and are positioned, and then an area where the patients are coming, which is considered a red area, and looking at the flow organization within the healthcare facility you're at to see what is the best way to move a suspect patient from this screening area to the nearest place where they can wait, and you notify, and guidance is given regarding where we're taking them next, which is not in too close proximity with very many areas in your healthcare facility. And maintaining a 1 meter distance and a physical barrier, either a table or a desk or plexiglass, like Sandy had mentioned. These are just an example of a setup. Commonly in our facilities, you'll see what is on the right. There's a table, there's a healthcare worker with the minimal PPE required, or if it's you have available resources, a plexiglass and a like on the left. Very key to use a non-touch thermometer, the infrared thermometer, and advise or orient whoever is screening about the temperature 38 and above. If you're taking temperatures below 35, we need to recalibrate the thermometer, but also we need to change the batteries frequently so that we are actually taking the right temperature and we are not reading wrong temperatures. While we screen, this information should be given to whoever is screening. For anyone with no symptoms, no exposure, according to the case definition Sandy presented, can continuously go to the health facility. For people with no symptoms but a history of exposure, this should wait while contact tracing hotline is called so that you're guided. For those that meet the case definition, that means you have symptoms, or you have symptoms and exposure, these are guided to the holding area or our isolation area according to the level of facility. Notification is done, and then evacuation of the patient takes place. So many questions have come through. What level of PPE should I use? So I'm going to start with what kind of PPE do you need when you're taking care of patients routinely, Ebola or no Ebola? There's no standard guide of what PPE to use. The PPE you're going to use should be guided by a risk assessment. Me as a healthcare worker, every time I'm in front of a patient, the first question I ask myself is, what is the anticipated risk of exposure to blood or any other body fluids or respiratory secretions, mucous membranes, non-intact skin, contaminated aerosols? Because the PPE you're going to use will be determined by the above. So if you anticipate the procedure you're going to do, that you're going to come into patient contact, you're going to touch the patient, you need to think about the hand hygiene, which we're going to look at, either using alcohol-based hand rub or soap and water if the hands are visibly soiled. And that includes the patient's environment, touching files, touching some of the things that are within drip stands, etc. If you anticipate direct contact with blood and body fluids, you're examining a patient who is telling you they have diarrhea, they are vomiting, they are coughing here and there. We need to ensure that we protect our hands with gloves. If there is a risk of splashes onto your body, you're delivering a mother, you're doing an operation, you anticipate any splashes. On top of the hand hygiene, you have to have gloves, you have to have gown. In addition to this, if you're anticipating a risk of splashes or sprays onto their body and their face, patients are coughing, you're having blood-related procedures, operations, normal deliveries, etc. On top of the hand hygiene, you have to have your gloves, your gown to protect the body, a face mask, and eye protection. So, which means that even at a bare minimum, with or without Ebola, if you're doing procedures that require that there is a high risk of anticipation of splashes, body fluid exposure, you need to have this level of protection, including things like a normal delivery. You have to have body protection, facial protection, because liquor can splash, blood can splash into your eyes. And using gloves and this protection does not remove the need for hand hygiene. Between patients, you'll have to change the glove. You'll need to perform hand hygiene before and after removing the gloves. And all the other standard precautions that we've talked about, environmental cleaning and the like. So this is the bare minimum. Always think, what activity am I going to do? What is the anticipated risk of exposure? Because we don't want also to put on a coverall to just be at OPD while you're taking a patient's BP, because the resources will not be available, but also the healthcare worker will be uncomfortable putting on this PPE. So if you take anything from today's session, always think, what am I going to do and what is the anticipated risk of exposure to my eyes, my mouth, my mucous membranes, my body, and also what is the patient presenting with, because that's what will guide the PPE. Now just tailor it down to Ebola. In terms of PPE, if you're screening and you're able to maintain a 1 meter distance and a no-touch technique, you're using an infrared thermometer. We do not advise us to use the digital thermometer, which you remove from one armpit to another while we are screening for patients at the entrance of the hospital. You do not require PPE. Just put on your scrubs or uniform. Also, as a bare minimum, healthcare workers in facilities should be working in a uniform or a scrub that does not leave the healthcare facility. And then if you're screening and for some reason you're not able to maintain a 1 meter distance, patient is very ill, patient is unconscious, you need to come into closer contact. You already have your scrubs, you have to add on a fluid resistant gown, facial protection, which includes a face shield or a goggle, a medical mask, double gloves, and rubber boots. Then anything that is for close contact to a patient, including triage, you're taking vitals, you're positioning patients into recovery position, you're taking the blood sugar, all those quick things we do while we're triaging patients, or you're doing actual patient care of an Ebola suspect or a confirmed case. Keyword here is suspect. Even when the patient is just a suspect, before we get the results, you need to be able to put on the full PPE. the double gloves, the eye protection, the mask, the coverall or gown with a hood, the disposable or reusable apron, and rubber boots. And then for the dead body management, patients who are suspect or confirmed cases for Ebola, and for people who are cleaning, cleaners, hygienists, waste handlers around suspect and confirmed cases, on top of the above PPE, you need to add on heavy duty gloves and heavy duty apron, because while you're manipulating, scrubbing things, the examination gloves may tear. So we need to have our heavy duty gloves and our aprons. I hope this is very clear for us. Just to re-highlight, screening at a distance, no PPE. Screening where a distance cannot be maintained because you have to come into closer contact to help the patient, PPE as has been prescribed. For just to highlight, we do have an SOP that I will request the secretary to share out the link. The SOP of the step-by-step on how to put on the PPE and remove it that we may not be able to do in this session can be shared. The principles is that we do not want to use PPE alone without the other APC precautions. People have to be trained on using the PPE, isolation procedures have to be in place, ventilation has to be in place, and the like. Also, just as a reminder, you can put on your PPE and still be exposed. From most of the healthcare worker exposure assessments that have been observed, during people who have used PPE and have still been exposed, this usually occurs at doffing, when PPE is contaminated and it's not removed according to the SOPs. But also sometimes we have PPE, but we have gloves on, but you're touching your phone, you're touching your pockets, and then later on you remove the PPE and then you continue using your phone, yet it has now been contaminated. Just to highlight that we can utilize the videos and the SOPs for us to undergo this training. We don't want you to put on the coverall for the first time when you have a suspect in front of you, because it requires a motor skill to be able to put on the PPE, feel comfortable in it without having to keep adjusting the goggles, etc. So hence, let's take it upon ourselves. As a pillar, we are also looking out and working with facilities to do demonstrations, but at least we can utilize the SOPs and the videos in the meantime. And the SOP really is just a step-by-step of how you'll put on and how you put off the different levels of PPE. Regarding isolation, as we set up our isolations, some of the things we've observed is that, especially in some of our private facilities, we want to have isolation as a private room somewhere, but let's have considerations of how close is this room to the entrance of the facility, but also how this room should not be very close to very many other areas, because once the patient is confirmed, then we have to think about decontaminating the whole hospital, thinking about how many healthcare workers have been exposed, but rather this should be a space that is as close as possible to the entrance where we are screening, but also separate from most of the other activities that are going on. And healthcare workers should have a way to put on the PPE in a green or clean environment, enter the red zone that is highlighted on the left, and then once they are done with this, have a way to remove the PPE and then enter back into the clean environment, which is so close to the red zone. So our isolation, according to the resources available and the level of facility, for a higher level facility, we can have an empty ward, a temporary structure, a room that can be identified from the OPD and kept for this. And for the lower level facilities, just any space where a patient can be kept and observed and being provided some shade and the like as we notify and wait for evacuation. Regarding cleaning of our environments, several questions have come through about how long Ebola can survive outside the body. And different studies and observations have showed that the virus can actually persist for several days, up to 21 days, depending on the type of surface and the temperatures in the environment. Just to highlight that viruses persist longer in liquid body fluids. So if there's vomitus, blood, etc., the virus is more likely to persist in that kind of environment, even outside the body. And in tropical conditions, like where humidity is high, the virus is likely to get destroyed compared to more humid conditions, rooms with less ventilation and the like. And this is just, we've looked at some different studies And on average, up to more than 14 days, there was survival of viruses, even outside the body. But this was in places that had a low temperature, high humidity, but also human blood or other secretions that were present, which means that we still need to decontaminate any places that have organic matter even after the patient has left. Commonly, if there's organic matter, moist environments, lower temperatures, absence of sunlight, and disinfectants in some of these places. And the implications for IPC is that surfaces are potentially infectious. Hence, even after the patient has left, the waste that was left behind, the surfaces have to be decontaminated with appropriate disinfectants. Commonly, we use 0.5% chlorine, but for medical devices, we can also use 70 to 90% alcohol. And ensuring that we have our cleaners have PPE. Our cleaners may not be on the call like Chair has highlighted, but we need to go back and orient them on the PPE that was presented in the earlier slide, same as the waste handlers. Cleaning and disinfection, we are not spraying as has previously been done. We are utilizing the buckets whereby you clean with soap and water, you rinse, and then you apply chlorine for the contact time, minimum 10 minutes, and you rinse off because chlorine can erode the devices we are using. There is guidance on how to constitute the chlorine. It's not a one size fits all because there's several solutions of concentration available, 6%, 3.8, and then there's also chlorine powders. But the principle for the liquid chlorine is the original concentration divided by the desired -1 to prepare 0.5%. So for example, if you had 6% and you wanted to get 0.5, you have to get 6 divided by 0.5 and you subtract 1, which gives you 11. And what are we using this calculation for? This means that for every 1 part of chlorine, you mix it to 11 parts of water. So if you're using a cup, you measure 1, and then the same cup is used to measure 11 parts of water so that you get 0.5. Very key to get the concentration because this is what is required to deactivate the virus, but also that is safe not to destroy our devices. There are also SOPs and IEC materials for this, especially for the solid, and this will be shared out to guide us how many spoons can I utilize if I'm using the powder of 65, of 90, of the different percentages. The key for the healthcare worker is that you have to look at the percentage which you already have to make the percentage you need. Like I've highlighted already, we don't want to spray because the spraying does not give us the contact time, but also it's been observed that the chlorine can cause respiratory issues in among the healthcare workers and the people that are using it. Hence, we need to first clean with soap and water, putting on appropriate PPE, and then we can disinfect for the contact time. Regarding waste management, waste still has to be segregated according to the type. Mainly, we have 3 types. We have the domestic waste, we have the infectious waste. Infectious waste is our red bin and our sharps container. And then for emphasis, any waste from Ebola treatment or isolation units is considered infectious waste, whether it's food leftovers, other patient-related items, as long as it's from your suspect or confirmed wards, it will be considered infectious waste. But for the routine waste segregation, some of the changes that have happened that healthcare workers have been asking about, there's been an effort to strengthen the management of the infectious waste by combining all those things we used to call infectious, highly infectious, etc. As long as it's infectious waste. There's nothing like highly, less highly. If it's infectious, that means it contains body fluids, either used gloves, PPE, soiled gauze, soiled cotton, etc. It's considered red waste. The only disclaimer is that if it's anatomical waste like a placenta, body parts, you have to have a separate bucket because the end disposal is different. Some of the facilities have a placenta pit where you're not going to be putting the gauze and the like. So you can put your placentas in a separate red waste just because of the disposal. But everything we used to put in yellow and the red bin will now be in the red bin and treated as such, managed by either incineration at site or stored and packed safely and transported through a pre-approved provider for off-site disposal. Then the rest of the waste is the black bin, which is food leftovers, packaging materials, etc. The brown bin for the pharmaceutical still remains, and the sharps box, which is puncture proof for needles, scalpels, lancets, etc. But I will just emphasize, if this waste is from the treatment unit or isolation unit for Ebola, all of it is considered infectious. We're not going to take it to the domestic waste because it's black waste. Hand hygiene, washing with soap and water when hands are visibly soiled, and disinfecting with alcohol-based hand rub at all other times. If these, for one reason or another, are not available, that's when we want to use 0.05% chlorine. This is an alternative for when the other two are not available, because you can get excoriations on the hands, etc., which then make your hands more liable at risk of exposure of infections. But in some cases, congregate settings, you have very many people, and you're not able to maintain the supply of soap and water or ABHR, you can utilize the 0.05% chlorine. This has to be diluted according to the SOP, otherwise it will cause the excoriations I mentioned about. For the healthcare worker, I know most of the colleagues kept mentioning wash your hands as frequently as possible. It's very key that we follow the 5 moments of hand hygiene at a bare minimum. We have 2 befores and 3 afters. Before touching a patient, before any clean and aseptic procedure, including cannulation, catheters, surgery, etc. After body fluid exposure, if you're from putting a catheter, even when you had gloves, you need to perform hand hygiene. After touching a patient, even during routine examination, because that's the way you protect yourself as a healthcare worker, you also protect the next patient. Perform hand hygiene. And then after touching patient surroundings, we are moving drip stands, we are moving patient care equipment, patient files. This is the bare minimum. And then you can wash your hands at any other opportunity, but at least at this bare minimum of the 5 moments, this poster is available. Let's have it put in many points in our facilities. Let's teach our students, interns, etc., so that it becomes, this should be routine practice. And realize that if you're doing this, you're protecting yourself as a healthcare worker, but you're also minimizing transmitting infections between one patient and another. The SOPs and the steps for hand rub and hand hygiene are also available. These can also be printed, but also included in our routine CMEs, so that we're actually performing hand hygiene according to the right steps. For handling of sharps, let's have our sharps boxes at the point of care, at the patient's bed, at the place where we are bleeding the patients, on the trolleys, so that we're not moving with needles up and down in the ward, but also not leaving them in mattresses and in the open air. There is an SOP that guides us on safe and dignified burials. Emphasis for this is that, as the previous speakers have mentioned, bodies are highly infectious. Hence, we are going to handle the bodies with care, suspected cases and confirmed cases. There is a burial team that, once notification has been made, can come and support. But on site, just for emphasis, is that we're not going to be handling bodies, business as usual, but also even during routine care. The mortuary attendants have to use the minimal, the PPE, including the rubber gloves and the like, while manipulating bodies, because we do not know most of the times what the body can also expose us to infections. Then as I come to the end, there are some other IPC precautions for us that have facilities that have had a confirmed case. We've seen some of these precautions in place, but sharing them here for emphasis. Whenever we have a confirmed case somewhere, we need to look at the household of the confirmed case, the healthcare facilities within the proximity of that confirmed case, and the community, and support with our IPC and WASH interventions to reduce the transmission in that predetermined area. And this area is considered about 0.5 kilometer radius in urban and 1 kilometer in rural settings. And the reason we are looking at this is, if a patient came to facility A, chances are that they could have gone to another facility within that same location. Hence, we need to quickly go to all these facilities, ensure their IPC practices are updated, but emphasize that we need to decontaminate the place where the case visited, from home through the different clinics and medical centers, Hence, we need to have our teams that are trained and ready to decontaminate these areas so that you remove any remains that could have or contamination in the environment that could have been left by the confirmed case to minimize transmission. And this has to be done at least within 24 hours so that you're able to protect the other patients, the healthcare workers, and alike. And then we do have an IPC wash readiness assessment tool that at this moment can be utilized by all healthcare workers, even including our IPC focal persons that are at the regional level, district level, and facility level to help us document the key processes, practices, availability of supplies and materials so that we can actually have interventions that are targeted on data that has been documented using a structured tool, so that we know that this is the area where we have gaps and these are the interventions we need to put in place at our facility. The tool is accessible on a link that will be shared through, also included here as a QR code, so that we can actually document our IPC practices and have targeted interventions to fill the gaps that are identified. This is just a list of the key resources that are available that will be shared or have been shared before. Also to highlight that we do have an IPC guideline that is from last year, January 2025, where the step-by-step precautions for IPC are highlighted, and the ones that are targeted to Ebola are included in the SOPs and the case management and IPC VHF guidelines, which are all available in the link that has been circulating around.
Evelyn,
Yeah,
you are
that was
there?
it from me.
Well done, Elizabeth. I know there might be issues with unmuting for my co-chair, Evelyn. Sister Evelyn is online. If you can unmute her. We have again been enlightened on IPC. So let's not have excuses. Let's ensure that we practice the required SOPs for IPC at the different levels. Now, she has emphasized the screening again, and the screening is not only at the entrance, the screening even for people who are admitted on the wards, the screening for healthcare workers as they come on duty. I think this was overemphasized again by our first presenter, and as they leave, so that we have records of every health worker and how they stand. The distance we need to keep between ourselves as we do the screening at the entrance and the people we are screening, the need for the holding and isolation and or isolation spaces depending on the level of the facility. And I think, and how to prepare disinfectants for our different surfaces. That the contact is not only, infection is not only through body-to-body contact with the infected person, but also if we get in contact with surfaces, with items that have been contaminated without adequate protection, we will be exposed. And to avoid that accidental exposure as well, to make sure that our surfaces and our materials that we use are properly cared for and disinfection is done. For that matter, in the next webinar, we will go through proper disinfection of contaminated surfaces. Do not miss that session. It will be a practical one. Elizabeth, kindly prepare for that one for our next session next weekend. Now we are going to, the link for the The few areas we want to learn from you is in the chat room. Click there and fill the form so that we can use that information for better planning for ourselves, but also for the rest of the country. Thank you for those who are appreciating government for the efforts. We thank you. We know government is all of us and all of you contributing, taking care that we do not get exposed, taking care that those who are exposed are properly handled, and doing active search at our respective facilities. Those of us who are in the high burden districts, which have been shown across the west, from the north, the western belt, we need to be extremely vigilant and prepared. This preparedness presentation is specifically for you. We will be working with you next week in those high burden districts to further understand the preparedness and also see how to strengthen. Those of you who do not have the PPEs, as we were posting on the chat, please order for the PPEs that are appropriate for your safety through the national medical stores or joint medical stores, depending on where you subscribe. Questions session is on. Evelyn, have you been able to unmute yourself so that you handle the question session?
Yes, Commissioner.
Okay. Please go ahead and get if there are any hands up or any questions which still need to be answered. Admins, please copy all the questions as have been asked. We need them for our reference and for other colleagues who are not here to attend to some of the concerns. Thank you. Over to you.
Thank you so much, Commissioner and all the presenters. Indeed, it has been a good teaching moment for all of us. And dear listeners, and just to sum up of what we have heard, we encourage each one of us to make sure that your safety comes first as we prepare, as we take care of our patients, and also continue to do our essential health services, because indeed we have to continue working and caring for other patients, but we keep vigilant and also remain alert and listening from our clients as they tell us what is happening in the community and what we can pick from their stories. So I encourage and also add my voice to say that we should remain vigilant. We work together as a team and we protect ourselves, our patients, and also communities at large from Ebola as of now. And the Ministry of Health, with all the departments, we stand with you and we are committed to provide the support you need to meet all the necessary safety and work effectively as we eliminate this pandemic. So I'm seeing, Stella, you are online and you have a concern. Kindly ask your question and we see how we can also respond. I'm seeing, if you're muted, please ask your question.
Thank you, Tim, for this very informative presentation. My question is about the currently approved, WHO-approved vaccines for the Ebola. Are they helpful in this epidemic? Is it possible that the health workers can receive, if they are helpful, if they can help? Over.
Thank you. Any other question?
Dula, you have your hand. Dula Ibrahim, you have your hand up. Please go ahead with your question or comment. Ibrahim Dula, please go ahead with your question or comment. We have a few more minutes. Ibrahim.
Okay, Amos Muhumuza. Please go ahead with your question or comment.
Good morning, everyone. Yes, thank you. Thank you, the commissioners on board, and thank you for the presenters, Dr. Sand and Elizabeth, for teaching us. My concern was about how do I handle the linen that this suspect, yes, we've had a suspect, has been transferred to the isolation unit, but the bed is on, there was linen. Hello?
Hello.
So how do we handle that linen when the suspect has been now transferred maybe to the treatment center through the appropriate ambulance? Do we wait for results, or what do we do with the linen? Thank you.
Thank you. Ibrahim, you are done muted. Please go ahead with your question.
Yes, thank you very much to the presenters.
Yes.
Yes, thank you very much to the presenters. I have like 2 or 3 questions and then a testimony. So the first question is at our primary screening place or area about the fevers and so on, or what do we do at that primary screening center? And then the second one is about the samples. We've not talked so much about laboratory samples, but which kind of samples do we pick from these suspects? And then 3, on Wednesday, my name is Dr. Dula, by the way, from Busia. I work with Durban Hospital. So on Wednesday, I had a scenario. I was called to do a postmortem on a patient that had been ill for around 7 days. He was first in clinics, private clinics. Then he ended up in a PNFP, that is Durban Hospital where I work. So he was managed in the hospital for around 2 days, then passed on Wednesday night at around 2. So they called me in the morning that
just questions.
It is actually important. So on that Wednesday at very early in the morning, I'm called to go and perform a postmortem. The parents or attendants were suspicious that maybe their person was poisoned. So I go and do the postmortem. I did some brief history taking because I was not part of the team that managed the patient. So I took some history, and they narrated to me that he had some bleeding tendencies. He was vomiting, and then vomiting blood and diureting blood. But my team did not suspect Ebola. So me too, the suspicion index was still minimal because he had a scan that was pointing towards portal hypertension. So I suspected that maybe he was bleeding from esophageal varices. But anyway, I went ahead and did a postmortem. I opened up and then found melena stool in the ileum. I mean, in the large colon, from the ileocecal junction up to the rectum. But esophagus didn't have esophageal varices, the stomach didn't have any ulcers. So I didn't really come up with a conclusive cause of death because I didn't get where that blood was coming from. So I made my report and went to the ward. So while on the ward, I think the family had issues. They went home, they were fighting over land and where to bury the deceased. And then the postmortem report was not yet out. And I gave it to a person who took off because he had sold the land of the deceased. And then, of course, they were asking for money for casket and organizing the ceremony. So he took off with the report.
Could you be quick, please? More hands.
Yes. So people became suspicious, and I think they called they had someone in the Ministry of Health. They were like, they had a suspicious person who had died in the community, that is Masaba in Busia. And then they were suspecting Ebola. So from nowhere, I received calls while I was doing a ward round that the patient had done a postmortem, was indeed a suspect of what? Ebola. So the only issue is that we had After the postmortem, we had treated the body. We had treated the body. The question is coming. The question is coming, please. We treated the body and we didn't have any sample. So I received a call from the DHO asking me for a sample. And the body was treated. Even the organs we had removed were totally treated with formalin. So the question is, in such a scenario, is it possible to still pick a sample from such? But lucky enough, I followed up with the lab. They had done a CBC on that patient and the sample had not been discarded. So that's the sample we offered in. But the question still stands, can we still pick a sample from a body that has been treated? Sorry for the delay.
Thank you, Ibra. Let's have maybe two more questions from Dorothy and Simon. The others, you'll take your questions after this first round. Dorothy Turitwenka and Simon Ayebare. Please unmute yourself and ask your question.
Thank you. Yes, thank you very much.
One question each. Thank you.
Pardon?
One question each, please.
Okay, thank you very much. My question is to do with the critical care options that you have available for the patients that get Ebola and then multiple organ dysfunction. Do we have these options set up, and do our teams also have the specialists that are able to treat these patients, especially with regard to the second death? Thank you.
Thank you, Simon.
Thank you so much. And my question is, how much have we engaged the CSOs? These are civil society organizations contributing to health, because like for my constituency, I serve the fishing community. I coordinate health response for fishing community. In the Great Lakes, these are also some of the vulnerable communities, even high-risk groups, because of many cross borders which enter people through the water channels. And we need a lot of awareness, and we have communication networks. Like for this meeting, I try to reach many of them to be part of attendance. But if this kind of education could continue, so that community are more vigilant, and where possible, we can equip those on porous borders to support, because the health workforce may not be everywhere, but when we also engage the community, I think it beef up the gap. Thank you so much. Back to you.
Thank you, Simon. There is also a question which was in the chat, and all the others have been asked or responded to, but one is about management of stigma for the families of those that are that have been affected by Ebola. To our presenters, I think you could respond to those questions quickly, and then we could take on another round after that. We can keep the answers short. We want to finish our session shortly. Elizabeth?
All right, thank you very much, Isaac. I will straight respond to the question about linen management. For management of hospital care linen, with or without Ebola, the linen handler should be actually putting on the PPE that includes the facial protection and the body protection, which is the rubber gloves and the aprons. And linen should be double bagged from the wards and transported to the laundry room. If a facility, the recommended rule will be to machine wash linen. If a facility has a washing machine that has hot cycles, then we can manage this linen as a like. For the facilities that don't have a washing machine, using PPE, we have to be able to disinfect the linen before we can actually wash it. Through utilizing hot water in a drum, we can stir with a stick, and once it has cooled down, transfer it to a 0.05% chlorine solution for 30 minutes, minimizing splashes, emphasis on PPE that includes the protection for the face and the body for the linen handler. I think that was one of the questions that was directed to the IPC section. Over. That's the one I captured, Simon.
Thank you, Sandy.
There is a question where Simon also asked about the CSO's involvement
and engagement. And I think in each and every districts, let's have the district task force engaged and active to be meeting in a weekly basis. And we all know that these task forces are always chaired by the RDCs. So we can identify the CSOs within the district. We engage them. We come and have a meeting with them, and we also make awareness. Then from that, they can see what they can support the district with to make sure that they work within the district as we prepare, but also to protect our communities. Then the stigma question, I think psychosocial support is the key. Talking to these people who are in isolation units or who have been affected or infected with the infection, we can always reach out to them, talking to them, visiting them, and encouraging them that they are moving on well and all will be well. But it is a continuation. It is not a one day off talk or listening to these people. But as we keep engaging, praying with them, talking to them, visiting them, providing food and drinks, that is the support we can offer as we move, such that we are not detached from them and they are also not detached from the community. Thank you again.
Thank you. We'll take on maybe the other question. Dr. Martha, I've seen your hand up. I don't know whether you had a response. Martha from Department of Pharmacy, Commissioner. I don't know whether you had a question or comment.
I think she's to help us to work on the issue of the PPEs.
I didn't have any comment. Nobody has asked anything.
Okay.
Commissioner Martha, those questions were in the chat that some districts don't have PPEs, that how can they be supported or helped? I thought you could give in an advice. It was in the chat.
So should I give the advice?
Yes,
Please go ahead.
Commissioner.
So thank you so much for giving me this opportunity. I have been hearing all these things. People are complaining that the commodities are not there and nobody is sending us orders. The orders that we receive, and currently we do not have any electronic system. We are working on it, but we need to take note that all the commodities, all the orders must be sent through this email. Please take note of this email and send all the orders for only Ebola. We are not saying send the orders of National Medical Stores. National Medical Stores has got what we call the NMS Plus or CSSP. Send your routine orders through that. But for Ebola commodities, send them to this email. We shall verify them at the Ministry of Health. And all those ones who are sending orders are sending us abnormal orders. You cannot send me an order asking for 30,000 gloves, meaning you want to deplete, you don't have gloves in the whole facility. So please send only Ebola orders to this email. We shall process them. No orders shall be honored at National Medical Stores without the approval of the Director General. So NMS will process these orders and then deliver them to you. Also, accountability of these commodities, we want to see accountability. We want to see accountability of the commodities. I don't know, my thing is disappearing. Can you see?
Yes, we can.
Most cases, we find that people are not accounting for commodities, even the mere stock card. they do not have. And then they start telling us they have written letters that we should stop using stock cards. And when audits come, how are we going to answer for these queries? And even ordering becomes very difficult if you do not have any accountability system. Because most of the facilities that we have called, people are saying, no, the EFIA is down, we don't have any report. We have told them, please put back the stock cards. The stock card is the primary tool for order, for making, for accountability. So create stock cards for these commodities and balance these stock cards for both medicines and medical supplies, so that when you are making your next order, you are able to provide us the stock on hand, and that is the balance on hand, and the new quantity that you want. We don't want incidences whereby you are sending us or are requesting for orders when you are holding commodities. Then at the end of the response, you are saying we have a lot of this and we don't, and things are expiring. So we want to see the stock on hand on your order. Also use the dispensing logs that are available for dispensing these commodities. We want to see that these orders, they are balanced. Whatever you've dispensed, you balance it at the end of the day and provide it in the stock card. The stock card, you'll only update it at the end of the week. And then people have been complaining that NMS is not delivering. But I have delivery notes showing that NMS is actually delivering for facilities that have requested. So please use this order form, this reporting. Report what NMS has delivered, because it's not fair for us to start saying NMS is not delivering, yet NMS delivered the items into the facility, and the person responsible did not even create a report and say the items are here. The facilities that I'm asking for the reports, they are sending me delivery notes. The delivery note is not the report. Give us the report, because that delivery note feds, so that at the end we do not come in, when auditors come, you don't start saying NMS is the one which has. NMS has done its part. Please provide us with a report, send a report, include the order date, the delivery date, and who prepared and who delivered these commodities. And please send us, still send a report to Ruduni and copy me in. Thank you very much. Only Ebola items, the routine commodities, please send them direct to national medical stores through the CSSP system. You all have it. Thank
Commissioner,
you.
there were questions about the private facilities as well. Should they also send to the same? I think it came through the chat.
We are only dealing with public facilities that are supported by national medical stores and PNFP facilities supported by joint medical stores. For the private facilities, I believe they know how they always buy their commodities, but they can buy them from joint medical stores.
Thank you, Commissioner Martha. I'm seeing someone
Yes.
on the chat asking about the vaccination of health workers. From the beginning, even from the DG's communication, we say that this Ebola strain, we don't have vaccination for it as of now. But this one doesn't mean that people are not working. But as of now, we have no vaccination for Ebola, Bundubujo strain, to be provided to the health workers. So let's keep calm and we do these other measures. If it comes, all health workers and high-risk people, they will be vaccinated. But as of now, we don't have. I think that, isn't it okay, Simon? Isaac?
Yes, it is. Maybe because we've run out of time, we can just receive only one question from Valence, a comment, and then we'll hand over to Dr. Stavia. We are over our time. One more, please.
Okay.
Quick, keep your question
Thank you
short.
very much. For me, it's not a question, it's a contribution from Dr. Elizabeth's presentation. on mixing powdered chlorine. There is a available formula. Maybe in the next presentation, I will be able to elaborate it properly. Then the second comment was from someone who was asking about the involvement of environmental staff for provision of sensitization and support to the communities on environmental cleaning and sanitation. And we are really working closely with them under the Department of Environmental Health, the Ministry of Health. I am Valence, the Principal Environmental Health Officer, Minister of Health. Thank you very much.
Thank you. Back to you, Dr. Stavia.
Okay, thank you so much, our presenters, the participants, and our facilitators and administration team that has helped organize this webinar. We'll continue next Saturday. And like I said, one of the things we're going to do on Saturday is how to conduct proper hand washing and disinfection. And then we shall also get any other new things that will be happening in the Ebola virus space. With that, allow me to make sure you have taken part in the poll that is running in the chat before you leave the meeting. The link is still coming through. Let me invite the Director General to close the webinar. Over to you, DG.
Thank you, Stavia, and thank you, members. And first, I want to appreciate, let's cascade this information beyond the members, beyond the members who are here, because if our members don't take precautions, they will be a danger to not only to themselves, to ourselves, and many other people. So let's take this seriously. I hope the materials, we should have shared all the educative materials here. I think there were others. I hope they have been shared. And then we also should have shared the contacts where information, all that was shared before on the previous presentation, where if they have information, where they should be able to report. We need all alerts, and we need to investigate them. We need them. So if also aspect of non-trauma mortality, we need to take them, and we need to take the samples before the bodies are embalmed. We should not make those mistakes, because the moment you treat the body, the virus gets denatured, and the results will show negative when people have already been exposed. No vaccines. The only way we can do it is really just being vigilant, following IPC. The VHTs, I've seen your questions. You're asking about materials, the queues. We've heard about your materials. I think we need to work. For communities and the workers and people in the border, let's institute community surveillance. Let the communities be the surveillance, because the border is porous. Anybody new? I know the communities are related, but let's, for now, be more vigilant. So thank you, and let's continue learning. Even me, I'm continuing to learn. Learning will not end. Thank you, Chair.
Thank you so much, DG, for staying with us and for encouraging us to continue the learning process. Let's put in practice whatever we have picked. The ones who are doing post-mortem, you need to get the appropriate gear to use for that. And for that exposure, for the concern you had, let's observe and see how things evolve on our side so that we can be supported appropriately. Thank you. Have a nice weekend. Over.
Thank you.
Thank you, everyone. Bye.
Thank you, everyone.
Bye.
Thank you.
Thank you.
Bye. Thank you.
Thank you.